Well, I am delighted that Dr. Pravin Nair has joined us all the way from just north of Mumbai in India. Dr. Nair, thank you very much for joining us. I know you are having an extraordinarily busy time at the moment, so I know this is it's quite a big thing for you to do for us. Can you whereabouts you are, Dr. Nair, and what your occupation is, what job you're doing just now?
So I am a clinical microbiologist. So I work in two hospitals in the city of Mumbai. One is a 300-bed hospital and another one is a 190-bed hospital. So both these hospitals, I am looking after the microbiology, including the infection control part of the hospital.
So does that include lab-based microbiology as well as looking after patients who actually have the infections?
Yes. Both are a part of my job profile.
Okay, sounds remarkably interesting. Now, what common infections do you see before we had the COVID-19 pandemic? What are the common problems that you deal with on a day-to-day basis?
So on a day-to-day basis, we used to have common infections like Salmonella typhi, then malaria, then seasonal dengue, tuberculosis, uh, and hepatitis A and E. That also again seasonal. So these are the commonest disease which we see in our daily practice.
Yeah, absolutely. And of course, all of those are potentially life-threatening conditions, aren't they? They're can be quite
Yes.
nasty diseases.
Yes.
Yeah. And at the moment, what is the situation in your area for COVID? Are you seeing many cases?
Yeah, there are a lot of cases coming up. So the lockdown happened in March 22nd. So one of the best part of the lockdown was the healthcare got enough time to prepare themselves for the pandemic coming. And now when the surge has come, actually the hospitals are quite a bit prepared to handle these cases. But
And
if,
yeah.
sorry.
So, sorry, have there been additional hospital beds provided in some areas?
Yes, there are a lot of additional hospital beds, ventilators, being provided, and even the quarantine homes have been created at various places in the city of Mumbai.
Good. So a lot of infrastructure has been prepared already, which is very encouraging.
Yes.
Yeah. Do you think there's a good oxygen provision as well? Of the things like medicines and oxygens, are they like provided, and are they at the levels that you are probably going to need?
Yeah. So India is a country where we have a lot of out-of-pocket spending. So the patients most of the time are not insured, and there's a lot of out-of-pocket spending. And the best part of this, there are pros and cons to both the sides of healthcare when you have total insurance versus out-of-pocket spending. But the best advantage is that you have access to the latest drugs or the latest treatment which is available in the country. And currently we don't have any shortage of either the drugs, diagnostics, or even oxygen for treatment of the patients.
Well, that's very encouraging to hear. That's really good news. How many cases are you seeing at the moment? Are you seeing new cases every day just now?
Yes, we are seeing new cases on a daily basis. So the hospital where I consult, which is a 300-bed hospital, so there approximately 15 to 20 patients might be visiting the casualty in a day. Out of that, maybe 5 would be requiring admission, and rest would be just home quarantine with mild symptoms.
So when you advise people to home quarantine, are you fairly confident people are doing that to prevent community spread of the disease?
No, actually, we are not very confident because India being a democratic country, every person has their own perspective. So when we talk about home quarantine, most of the people don't understand by what exactly is home quarantine. And we have language barriers. So India as a country is divided based on languages. So we find that also a challenge for implementing the home quarantine in totality.
So you've got a lot of your work ready to do for health education. There's a lot for
Yes,
you to do in health
yes,
education.
you're absolutely.
What sort of clinical features are people coming into hospital with? What are they actually complaining of?
So, to tell you frankly, most of the cases what we are seeing initially were mild symptoms. They used to come with fever, cough, and subsequently now we are seeing a few patients coming with breathlessness. But when we actually evaluate them, the problem is with media. There are a lot of media videos, information going around in the WhatsApp or the news channel, which tells that these are the symptoms. So even though a patient might not be having the symptoms because of reading too much information, they have that mental block that okay, I am now going to succumb to the disease. So then they start developing those kind of fictitious symptoms, I would say.
So you're describing really a nocebo effect here, aren't you? A widespread nocebo effect.
Yes, yes. So the sometimes we feel that educating too much is also having a backfire on controlling the pandemic, because people feel that okay, this symptom I have got, so fever means every fever they feel okay, this is COVID. Every cough they feel okay, this is COVID. So it's more like a panic situation rather than the ground reality.
Mm-hmm. But despite that, you are having patients that are genuinely sick who have low oxygen saturations and other complications.
Yes.
Yeah. Are you seeing other complications as well as low oxygen saturations? What other problems are you seeing?
So it depends on the patient profile. If a patient is above 55 with comorbid like diabetes, hypertension, or already on immunosuppressive agents, we are finding that these kind of patients are having more complications, and they are taking more time to recover.
Mm, mm.
But just today there was a news in the paper that a 103-year-old male has recovered from a cytokine storm and has gone home. So we are seeing both spectrum of cases where young are coming and succumbing to the disease, and old are actually recovering and going home.
So are you seeing relatively young adults who are quite sick in your practice?
Yeah, so what we are learning from this disease. Actually, we are learning every day. There's a learning curve for us.
Mm.
So it is not hard and fast rule that those with old and comorbid conditions will definitely succumb. It's not like that. We are seeing a lot of young patients also coming in and succumb, but currently we are not doing any research to find out whether those young patients had some other underlying illness, because we are overwhelmed with the work which we are having currently. But maybe if later on when we analyze the data, we can come across that okay, these young patients had some underlying disease or illness which was not diagnosed.
Do you think there's a lot of undiagnosed diabetes and hypertension in the community in India?
Yeah, see, the lifestyle of Indians have changed over the last few decades. Okay, so we are a community which is not exercising. The sleep pattern has changed. The work pattern has changed. So all this lifestyle-related disease has increased in India,
Hmm. So
and
it's
that
what we used to call Western style diseases are now becoming more prevalent in Asia and India as well.
yes, definitely,
And obesity?
yeah, recently. The reason is because the work pattern. So,
Mm.
if I am working in an IT industry and the IT industry is based out in US,
Yeah.
then I have to work according to the US timings.
Yeah. Yeah. Oh,
So,
yes, of course. Yeah. Yes,
so
of
my
course. I never thought of that.
yeah,
We know that sleep disturbance is a big factor in immunity, don't we? It's
yes, yes, yes,
absolutely. Now, the comorbidities that we've talked about, the obesity, the chronic lung disease, the chronic heart disease,
yeah,
the hypertension,
yeah,
they're all known to increase the risks that people have in getting more severe COVID-19 disease.
Yes.
But with the other infectious diseases that are around in India,
Yes.
for example, if someone has COVID-19 and they get dengue at the same time,
Yes.
what do you think that will do to their prognosis?
So that is a fear which we are having with now the rainy season setting in. There is already dengue and malaria cases we have started diagnosing, and the worst fear is that a patient of dengue coming in as masked COVID. So we would be treating it as dengue, but actually the underlying main this would be COVID-19. So we are keeping our fingers crossed so that luckily we have diagnostic armamentarium to diagnose all this. So hopefully we won't face those kind of hurdles, because once the diagnosis, laboratory based diagnosis is done, then the treatment becomes quite streamlined.
But what we don't, I think what you're saying is what we don't really know at the moment is if someone gets both infections at the same time, we're not sure how that will affect their prognosis and the case fatality rate, in fact.
Yeah, definitely, because in both of the disease you have fever, both of the disease you have body ache. So a patient coming into the casualty coming of fever and body ache, currently we would say that okay, it is COVID-19, but maybe we have misdiagnosed dengue in that case.
Yeah.
So that the fear is always there amongst us that we might be misdiagnosing certain cases.
One of the things I'm worried about is not so much the misdiagnosis, it's when the influenza season starts again and people
Yes.
have both viral infections at the same time. So they might have influenza A and they might have COVID-19. And the concern is that that's going to cause a much more severe illness. Do you think that's a justified fear?
Yeah, it is definitely justified, because October, November is usually the time when the H1N1 season sets in, and then it would be again a confusing picture for us. What is the disease we are treating?
And is tuberculosis a common thing in your practice? You see a lot of tuberculosis.
Yeah, I do see a lot of cases of tuberculosis, but I cannot make it a blanket statement. But what in currently we are seeing is we are not finding a lot of TB patients coming in with COVID-19.
That is encouraging. That is very encouraging so far.
Yeah, but I would not jump to conclusions. Maybe these patients are not exposing themselves outside to the, because they are in strict lockdown. That could be one assumption, but currently we are not seeing any patient on tuberculosis coming with COVID-19
Good,
in my
right.
practice at least.
That's good news. And with your protocols, how long does it take to treat someone with tuberculosis? Is it 6 months? Is it a year?
So it depends on whether it is pulmonary tuberculosis or extrapulmonary. Pulmonary usually is 6 months. If it is extrapulmonary, maybe 9 months. But if it is multi-drug resistant, it might go to a year or more than that also.
I see. Yeah. Yeah. So these people know they have the condition, so they know it's important for them to shield themselves because of the potential increased risk. Yeah. Do you think HIV is going to be a particular risk with immunocompromise, or do you think that's going to depend on how well the viral load is reduced with antiretroviral treatments?
HIV, because yes, HIV could be a challenge, but we are not finding many cases of HIV patients coming with COVID-19 as on today. But what we are seeing is amongst the dialysis patient, those who are in acute renal failure.
Right.
They are the ones who are coming with COVID-19, and they are the ones who are actually succumbing to the disease.
Right. So quite a few of the fatalities had the chronic renal failure. See, chronic kidney disease comorbidity.
Yes. So what I am seeing in my practice is, like, if patients are on chemo, HIV, they are not getting severe infection with COVID-19, but dialysis patient, yes. they are getting severe infection.
Right. Okay. I'm very encouraged that you're not seeing the severe comorbidities so far with the other infections. That was a great fear, and what you've just said is really quite encouraging at the moment. That's good. Now, when someone has a fever, for example, with dengue or with COVID-19, is the sort of philosophy of your care to see that fever as part of the body's natural immunological response,
Yes.
rather than something that needs to be treated independently of the etiological underlying organism?
Yes. So fever is a body defense mechanism. So if fever is not there, you don't come to know whether your body has been attacked by a virus or a bacteria. So we always tell the patient that fever is a good sign.
This is
So
a message the world needs to hear, doctor, I think.
yes, fever is a good sign.
Yeah.
So those patients who are immunosuppressed due to their therapy, like we give them steroids to keep their maybe rheumatoid arthritis under control, or cystic fibrosis or interstitial lung. So these patients doesn't develop fever, and when they
The steroids stop them developing the fever.
fever, and actually it masks the disease, and these are the patients who succumb to the disease because the fever is masked.
Right. So you don't recognize it, and you don't have the immunological benefit of having the fever itself.
Yes, yes,
Yeah.
definitely.
So are you reluctant to prescribe antipyretics in your routine practice?
So we tell them that if your fever is 101 degree Fahrenheit, maybe you can take antipyretics. But if it is 99, 99.5, wait. Many a times the body immunity will take care of the fever part. So most of the COVID patients we are seeing, the fever is like 99.5 and 100. Very few is going into the range of 100 to 103, like that.
Yeah. Yeah. So the fever is self-limiting, because a lot of people worry that the fever will go higher and higher and higher and higher, and they'll
Yeah.
die of the fever. But this is a common myth, isn't it? It's
Yes,
just
yes,
not true.
yes. So the most panic in the COVID-19 is also the fever, which actually we should educate the people that fever is a good sign. If fever is there, as long as it is not going above 100 to 103, and the body is able to control the fever, or if it is coming down with antipyretics, no need to panic.
I see. Okay. So if antipyretics do reduce the fever, that can be a good sign. But fevers which are not responsive to antipyretics can be sign of a more serious infection.
Yes, yes. So that is
Interesting.
where you need to seek an expert opinion and get yourself evaluated.
Right, because we've often said that someone has a fever despite getting paracetamol or acetaminophen.
Yes,
So that does indicate that the underlying infection is potentially a more serious infection.
yes, yes. We need
Yeah.
to test them, maybe do a chest X-ray and see what is exactly happening inside.
Another concern I have, especially about the situation in many countries where people might not have ready accessibility to healthcare, is, have you any idea what proportion? Well, first of all, let's say that people with viral chest infections are more prone to bacterial chest infections. Is that generally your experience?
So usually what happens, patients develop viral pneumonia first, and they recover from it, but then their immunity gets suppressed because of this viral pneumonia. And when they go out to the community, or even when staying in the hospital, they can get a superadded bacterial infection. So that is a very well known fact.
And that's fairly common in viral pneumonia.
Yes,
Right.
very common in viral pneumonia.
So do you suspect this is going to be common in COVID-19 pneumonia as well?
So what we are seeing currently, because there is a lot of health education going around and patients are little bit careful. So those patients who are having COVID-19 pneumonia are following the guidelines given to them by the rule. They go home, self-isolate, self-quarantine, and are taking the treatment on time. So we are not finding superadded bacterial infection with COVID-19 as of now. It could be related to the patient's response to the media and the information which is coming in that it is lethal, and the whole idea that okay, I suffered from COVID-19 makes the patient go and sit in one room quietly till the immune system is again fully functional.
So in a strange way, the anxiety is useful to prevent the community
Yes,
spread. It's unpleasant
yes,
for the individual at the time,
yes.
but if it's preventing transmission, then that's interesting.
Yeah, that's interesting. And I think this is the first time a pandemic, because of pandemic, we are not finding other pneumonias coming into the hospital.
Right. This is an important point, isn't it? People that would normally come in for treatment are perhaps frightened to come in for treatment. So,
Yes.
so are you concerned that this could be causing more undiagnosed morbidity and potential mortality in the community?
There is a probability with patients who are already immunosuppressed due to their underlying disease,
Yeah.
but otherwise, usually patients who are now contracting any fever or cough are going to the hospital to get an opinion of the fear that it could be COVID. So they are getting themselves evaluated. So that could not be a challenge for us actually.
But people with other conditions might not be seeking the medical care that they need because of the fear of the COVID.
Yes. No, but usually COVID itself has set in such a fear among the public that first sign of fever or cough, they rush to the hospital.
Right. Okay. Yeah. 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 So, generally speaking, though, you think that a fair proportion of people with COVID-19 might need antibiotic treatment at some point in their recovery.
What we are seeing is those who are young, like in the age group of 19 to 25, 30, those who are athletic, those who have been maintaining their body weight proportionately, they are not requiring any intervention per se. But those with little bit weight imbalance and they are not used to exercise intolerance is there, so their lung capacity invariably is less. So these are the kind of patients who require antibiotics or supportive therapy to come out of the disease.
So the comorbidities are making the disease with the viral COVID-19 more severe, but the comorbidities are making the bacterial secondary infection also more likely to occur.
Yes, yes.
Yeah,
Definitely.
interesting. Yeah. So when a patient comes in with a fever, how do you tell if it's bacterial or if it's a viral infection?
So we have a protocol where we do the baseline test like CBC, complete blood count,
Yeah.
and we do CRP, serum ferritin, LDH, lactate dehydrogenase. Those are the tests which we do.
Yeah.
So it gives us a rough idea of what could be the cause of fever. If
So
the
yeah.
fever
So
does not,
if you just look at those examples, if that's okay, is the CRP more likely to go high with viral or bacterial infections?
in both, but bacterial it grows very high.
Right.
Yeah, C-reactive protein in bacterial goes very high. In
Right.
viral, it is not that high.
Right. So viral it goes up a little bit. Bacteria it tends to go up a lot more.
Yes, yes,
Yeah. And I think we should just say that C-reactive protein for the non-medical people watching it is an inflammatory marker, isn't it?
yes,
It
definitely.
indicates the amount of inflammation going in the body.
Yes,
So bacteria cause a lot of inflammation, in other words.
yes, you're right.
Yeah, that's really useful. And what about the bloods? What are the main things in the blood that would differentiate between a viral and a bacterial infection?
So we look at the lymphocyte to the neutrophil ratio. That is one which helps us to know whether it is a bacterial, and even the total counts.
Yeah,
So in a viral infection, the total counts usually don't rise very high, but
yeah.
in a bacterial, the total counts rise very high.
So neutrophils tend to go high in bacterial infection,
Yes.
and lymphocytes tend to go high in viral infection.
It depends on the stage of the disease. So there is a lymphocyte to neutrophil ratio which we calculate to know whether it is a bacterial acute onset or a viral acute onset.
I see. I see. Now, quite a few of the early researchers on COVID-19 said that people developed a lymphopenia, a reduction in the number of lymphocytes. Are you seeing this, that people are neutropenic with acute COVID-19?
No, so we have a chemotherapy department where a lot of patients are still coming in for chemotherapy, but we are not finding them getting infected with COVID-19. Very few, one or two, but not as I would say dialysis patients.
Yeah, but as well as that, are you see? Do you think that that the COVID infection is reducing the number of lymphocytes? Are you seeing that people
Yes,
having a low number of lymphocytes secondary to the COVID-19?
yes, definitely. We are seeing very low number of lymphocytes secondary to the COVID-19.
It's strange because you would think that the lymphocytes are fighting this infection, so the number of lymphocytes to go up.
Yes,
But
you're
what we're
right.
actually seeing is the number of lymphocytes go down.
Yeah. So,
Any explanation?
so I don't have an explanation. So what we are presuming is that COVID is basically a disease where we are learning. So even the cytokine storm in COVID, it is not caused by the virus. It is just caused by the immune response against the virus.
Yes.
And the rise of D dimer. Again, it is very astonishing for us. D dimer is something which we don't see rising in a viral infection like this.
But the D dimer is going up.
Oh, and many times we are using D dimer as a marker to say that okay, this patient could be COVID. Let's do a COVID test and see.
Right, it's that precise. Now, I think we should explain to people watching that the D dimer test is a test for when a blood clot is being broken down in the blood.
Yes.
It's a thrombin degradation molecule. So what this means is if the D dimer is high, that these patients have been having intravascular coagulation,
Coagulation. Yes.
blood clots in the circulatory system.
Yes. Yes.
Yes. Now,
So,
do you know if that's big blood clots like DVTs and PEs, or is it microemboli?
so it is microemboli, and what we are seeing is these D dimer levels are invariably going high in patients who is COVID-19 with moderate or severe symptoms. So
Right.
we have to start them on low molecular weight heparin to.
Heparin, of course, is an anticoagulant. It's going to reduce the blood clotting. And
Yes,
it sounds like some people are actually potentially dying of the blood clotting complications. So heparin could be a life-saving intervention.
definitely. So now the protocol has been changed where low molecular weight and even dexamethasone steroid has been added as a treatment protocol.
We know the dexamethasone is efficacious from the UK study, actually, where
Yes,
dexamethasone was shown to reduce mortality in patients who are sick enough to require oxygen and
yes,
patients who require ventilation.
yes,
There's a benefit to that. But
yes,
I don't know of any trial. I mean, what you say about heparin makes perfect sense, and I'm convinced it's a life-saving intervention. But we have no trial data on that yet. So, as you say, the novel virus, we're still learning that. Yeah. Is there any other important messages, Dr. Nair, you'd like to give us? Anything else you think that's important I haven't asked you?
So one thing is there that this is a new disease. Uh, the human body has never been exposed to the disease, and it is good that we have come up with diagnostic facilities and even the treatment protocols within a very short span of time. And I feel that is a collaborated efforts across the world, each country teaming up together and trying to find how to diagnose and how to treat the disease.
Absolutely. Yeah.
And if we work together, the world would be a better place for humans and other animals also.
Indeed, absolutely. I don't. You'll get no argument from me or anyone else on this channel on that. I don't think. Yeah, thank you. Can I? I've just thought of one more question I want to ask, if you don't mind. Just one thing.
Yes, sure.
I don't.
Sure.
I don't often have access to such expert opinion. So there's other coronaviruses around, for example, that cause common cold type features.
Yeah.
Do you think that if people have been exposed to those, that's going to give any degree of immunity to this novel virus? Do you think there's any cross immunity, or is this virus so different that exposure to previous not so pathological coronavirus is going to be of no difference?
So coronavirus is not a new virus. There has already been 3 strains of coronavirus which was there, but COVID-19, what the scientists say, is an absolutely new strain of virus to which the humans have not been exposed. And the way it has spread across the world and the varied symptoms, like some patients presenting with diarrhea, some patients presenting with anosmia, indicates that this is not same strain. It's a very new strain of virus which has come de novo, or we don't know the source as on today.
I would love to know.
Yeah. And for us, when we see patients having different clinical presentations, see, now when you talk about dengue, we know, okay, patient comes with fever and the platelet goes down and there's a rash. So it's easier to diagnose dengue even without a lab test, to tell you frankly. But when it comes to COVID-19, the presentation of the patient is so varied. So we feel that it is definitely a new virus.
So you don't expect the fact that I've had exposure to coronavirus that's caused a cold before is not going to give me any immunological advantage?
No, I don't think so. I don't think so.
Right, yeah. So it is completely new in that respect. Yeah.
And that is why the whole panic around the virus is there. If it was cross immunity, then there would not have been that much panic around this virus per se.
That's a good point. Just one last thing. How do you see things going in India over the next few months? Are you optimistic? Are you pessimistic? Are you worried?
To tell you frankly, I'm worried because see what happens in a democratic country. When you say that, okay, you are free to move around, there is no social distancing happening, and though we say that mask is very important part of your attire, people don't want to follow that. So I definitely predict a second peak coming in, and I don't see the disease becoming a low line till November, December. So the whole year of 2020 is actually gone.
And now that the monsoon season is here, that's going to be perhaps an additional problem for.
Definitely.
Yeah. So you think for the rest of 2020, at least, India is going to have this problem?
Yes, definitely.
Yeah.
Because look at herd immunity.
Sorry, go ahead.
So they are saying that 60 to 70% of the population should develop herd immunity to have a baseline cutoff. But if you look at the population of India, that 60 to 70% is a huge number.
It's like 800 million people.
Yeah, and we have not reached even half of that actually.
Oh, no. And have you any ideas what the overall case fatality rate might be, or is that not an area you'd like to speculate on at the moment?
Case fatality, we are looking at the data, but we will have to collate it. So age-wise, comorbidities-wise, and maybe as the months go by and we have much more data, so we can definitely share. But as on today, what I'm seeing in the casualty or in the hospital setup, not many deaths. Those patients who are dying are the ones who are coming in very late. They are coming to the healthcare sector very late. So then it is very difficult for us to salvage. But those who are coming to the healthcare system at an early part of their fever or cough, we are able to intervene, and then they are going home, even though they are having comorbid conditions.
That's very encouraging. You're able to give the supportive care that's necessary for all this.
Yes.
Yeah. Do you think there's any prospect of a specific effective antiviral drug for COVID-19?
So it is going to take uh, close to 1 to 2 years to actually find out if there will be a specific antiviral. Like H1N1, we know that oseltamivir or Tamiflu is the drug of choice. But with COVID-19, it is going to take close to 1 to 2 years, because now we are talking about adult COVID-19, but we have a subset of pediatric COVID-19 also. So there are a lot of children who are coming with Kawasaki disease, which we say.
Ah,
Uh,
really?
yeah. So
So that's
there are.
pediatric multisystem inflammatory syndrome.
Yes, right. Absolutely
You're
right.
seeing quite a few cases of that.
We have not seen quite a few, but 1 or 2 cases we are definitely seeing.
Oh, that is concerning, right?
That is
And you're pretty
concern.
sure that these are caused by COVID-19 as opposed to another virus?
Yeah, because we don't have that prevalence of Kawasaki is very less actually.
Right. So that is a concern that this could be affecting children as well as older people with comorbidities.
Yes.
Yeah. Well,
So the
let's
long
hope
term.
those numbers turn out to be very small.
Yeah. So we actually are not currently knowing what is the long term sequelae of this virus. So those who have recovered from the infection, whether they still have fibrosis of the lungs or they have damage to their other organs. So these are the things which are still unanswered.
And we know that some patients have troponins, don't we, indicating myocardial damage.
Yes.
Yeah. So it's not. There could be a burden of morbidity for some years to come as a result of this
Yes.
pandemic.
Yes.
Yeah. Did you think that this virus will be eliminated like SARS, coronavirus type 1, or do you think this could become endemic?
No, so I have a different school of thought. So if it is biologically made in a laboratory, this would not have a long term. It won't become endemic. But if it is not made in a laboratory and it is a natural virus, it won't be still endemic, because now we have started doing the antibody testing, and what we are seeing is that anti-IgG levels are coming down on those who are already suffered the disease. So it means it has a very short-lived immunity.
Does that mean people could catch it twice?
Yes. So
How
I,
long?
I
How long a gap?
so maybe 2 to 3 months. So IgG they are saying remains for 49 days. So after 49 days, what?
What about the IgM? Will that last for? Is the IgM even shorter term?
It is also short term. So IgM, IgG, IgG is one which remains for longer time. IgM comes initially. So they are saying it remains for around 23 to 24 days. And even I am seeing in my practice when I am testing the IgG, IgM antibodies. So many of those who have already recovered from the disease, their IgG levels are going down to the baseline.
But presumably the memory lymphocytes would still be present in the blood.
Yeah, that's why we are again keeping our fingers crossed.
That's the hope. Yeah.
Yes.
And these memory lymphocytes could undergo very rapid clonal expansion.
Yes.
And hopefully a new population of plasma cells that
Yes.
will
Yes.
produce huge amounts of IgM and IgG in no time at
Yes.
all.
Yes.
We hope.
Definitely.
Yeah. The other thing I'm hoping is that there's going to be an immunological signature still left in the mucous membranes, in the mucosa. Because we do know that some immunoglobulins are present in the mucous membranes of the body.
Yes. Yes.
And that could also be a factor in preventing local infection, we would hope.
Yes. Definitely.
Yeah.
But we are not finding that still the infectious rate of the virus is very high. So the transmission is very high. So
Yeah.
I don't think your local mucosal defense mechanism are helping much in this. Like IgA antibodies are not helping much in COVID-19 at least.
It's the IgA that's in the mucous membranes, is it? Is that the?
Yes,
Yeah,
yes,
yeah. So basically, all our hopes are stayed on the memory lymphocytes that will remember the nature of this infection.
yes,
Yeah, let's hope that's effective. If people
yes.
were to be reinfected, though, you'd expect the disease the second time to be milder if they have
Definitely,
the memory lymphocytes.
definitely. It has to be mild. That's how our body is programmed.
Yes, and hopefully mild enough to be asymptomatic.
Yes, yes, agreed.
And that's another thing we at this stage we simply don't know.
Yes, we don't know actually.
That's I didn't know the IgG only lasted for 49 days. That's new for me. That's fascinating. Thank you. Appreciate that. Yeah. Doctor, I know you've had a busy day. I know you've got phone calls to take all evening, so I don't want to take up any more of your time. But thank you very much for this, and
Thank you, Mr.
that this
Tom.
information is just invaluable to people around the world. So we really appreciate you taking the time to do this. So
Thank
thank
you.
you, and I
Nice
hope
talking
you're not too busy this evening.
to you. No, no, it's fine. Thank you, and it was nice talking to you. In
No,
fact, I feel you are equally knowledgeable as me.
I certainly don't think that's true, but but thank you, thank you, thank you,
Thank you. Thank you.
thanks.
Bye.